On the 6th day of extractions, my dentist said to me, the ID nerve I cannot see.
In this video, we're talking about a coronectomy of that lower right 8. And when I look at the OPG in this case, what I'm looking for is the outline of the ID nerve. And in this one, I can see that there seems to be a slight area of interruption on the upper border of the ID nerve. And in those cases, I tend to investigate that further before offering a procedure, because I'd like to know exactly where the roots are in relation to the nerve. So we proceeded for a cone beam CT on this, and if you look here, you will notice that the ID nerve is being squashed towards the lingual side between the roots and the lingual plate. And as such, we should offer a coronectomy for the patient to minimize the risk of damage to the ID nerve. If they decide to go for the full extraction, then that's absolutely fine. In a coronectomy, what we're trying to do is to get rid of the crown of the tooth at the level of the CEJ and smoothen off that area, close the tissue completely to give us adequate healing, and hopefully the roots won't move. I tend to use a 3-sided flap because I need to be able to approximate that flap to cover the area where the crown was in the past. The closure in these cases has to be nice and tight. It has to be watertight if possible, so hopefully we've got separation between the oral cavity and the roots left in situ. So looking at this tooth, what we do, I start with my 3-sided flap. I start with the mesial cut, and I'm usually quite definite all the way down to periosteum. Then I will flip my blade and I will go across the crown to separate the tissue from the crown itself. And then I'm feeling my external oblique ridge and making my cut deep down all the way across the external oblique ridge, not going lingually to minimize any damage to the lingual nerve on that side. You have to be very gentle when you lift your flap on this side because you want the soft tissue not to be traumatized, because you need it for the healing process. So we're going to start now with the drilling process, and what you're trying to do here is initially create a small buccal cutter, not a very deep one, and then you have to adjust the angulation of your drill in order to be able to cut the crown from the roots without aiming downwards towards the pulp chamber too deeply. So as you can see here, I am just undermining the crown, and I'm taking my time to do that just to make sure that I'm in the right orientation without causing any damage to the soft tissue of the lip. As you can see, I've got 2 retractors in position there. So as I'm continuing, I tend to use a round burr because I'd like to see where the tip of that burr is at all times, and I continue to do that until I feel I have undermined enough to be able to do that separation. So I'll use a Coupland or a luxator. Very slight motion, and as you can tell here, there is a slight motion of that crown. That tells me that the crown has now separated from the roots. I'm not very vigorous in this motion because I don't want the roots to come up with me at the same time, because if the roots are dislodged or moved, they have to be taken out. So I continue now by dividing the crown in a buccolingual orientation into 2 pieces to be able to deliver it easily without causing much pressure on the adjacent 7. So now, once I've separated that crown, I will break it with my luxator and I will deliver the distal aspect of the crown. So that's your distal crown out, and picked it up with my Ficklings. And now I'm going to deliver my mesial crown, and that's my mesial crown out as well. So that's what you're left with. You're left with a nice, healthy, vital pulp tissue in that area. And your job now is to make sure that the area is very nice and clean of any surrounding soft tissue. So I use my Mitchells. I go around, check for any lumps, bumps across that side. I will use a sharp edge to get rid of any tissue between the tooth itself and the adjacent bone. And if there is any tissue, then I will curettage out that area completely, because I'd like a nice clean area for healing. So I found some tissue here. I'm curettaging that. I'll pick it up and get rid of it completely. And then I will smoothen off all those edges that I have. So I'll use my round burr, smoothen off the edges of the crown, make sure it's at the level of the CEJ, and I'll try and keep that level of the tooth slightly at or just below the adjacent bone on all sides. So I'm just smoothing up the edges as much as I can. To be honest, I think a coronectomy is a much more technically demanding procedure than a simple extraction, because there's so many extra steps that we have to do with this to make sure that we don't have to go back in there and do a full removal procedure. So I'm cleaning that out completely. Once I'm happy with what I have over there, I will start the closure process. And as I said, the closure process has to be a watertight closure to achieve good separation. So I'm closing now, and I usually tend to use a 3/0 Vicryl Rapide on a 5/8 needle. Start with that mesial relieving incision and the papilla in that position. Place it lingually onto that side. Don't go too deep lingually because you don't want to catch the lingual nerve at the same time. But then tie it nicely so you've got a good approximation of those tissues together. In the normal wisdom tooth extraction, I tend to put just one more stitch across the distal relieving incision, but in those cases I tend to do two, just to give me that watertight closure that we were talking about earlier. So you've got another stitch here on the distal relieving incision, and just tie it nicely into position. In a normal wisdom tooth as well, I don't tend to close that mesial relieving incision, but in this case I will, just to give me that complete separation. So as you can see here, you've got a nice separation between the oral cavity and the tooth, and hopefully we won't have to go back in there and do anything with that. There you go, coronectomy before and after.
On the 6th day of extractions, my dentist said to me, the ID nerve I cannot see.